Right, I think we should make a start then. So, welcome everybody to Scalpels Without Borders, the first podcast initiative of InciSioN UK. So, our podcast series will focus on global surgery. We'll interview major personalities who've made great advances in global surgery around the world. The idea behind this podcast is to inspire our listeners about the challenges and innovations in global surgery. So, to kick off our episode one, we have with us Mr. Alwyn Abraham. Mr. Alwyn Abraham is a consultant orthopedic surgeon in University Hospitals of Leicester. He's the TPD for East Midlands South Registrar Training Program. He's also co-founder of the Leicester Gondar Orthopaedic Partnership in northern Ethiopia. Apart from his accomplishments, he has also been a champion for international medical graduates in the UK. He has initiated a trust registrar program. He enjoys the challenge of mangled limbs with his particular field in limb reconstruction. So those were just a few highlights. I'd definitely be here all day if I wanted to list out everything about him. So without further ado, I will hand over to Mr. Abraham to take us forward with this session.
Jeff, thank you very much for those kind words. The topic I've chosen to talk about is a topic which is of particular interest to me. And as we go through the presentation, as we go through the talk, I think you will see how my exposure to surgery and trauma surgery in austere, limited environments has really inspired me and driven my interest in this particular field. So if you feel able, please, and all of you will be able, please feel led to answer the question in the chat. There are no wrong answers. I'd be interested to know what you think is the most important orthopedic development in orthopedics ever. Perhaps by the end of the talk, you might agree that I have a particular answer in mind, and you might wish to concur with me. Anyway, um, out of interest, does anyone know where that picture might be taken? Any guesses? Any intrepid travelers who can tell me where that picture is taken?
Mr. Abraham, I think we can't see your screen at the moment. If you try
Oh, I
sharing again.
apologize. Yeah. Okay. Hopefully you can see it now. Can you see it now? Yeah. Okay. You're okay. Yeah.
Yeah, we can see it.
Thank you. Okay. I wonder if anyone can tell me where that picture might be taken. It's a very unique landscape, and I know at least one of you will recognize where that is. Any guesses? Any educated guesses? The clue is obviously in the fact that this is a topic that involves talking about Ethiopia. So that is in Ethiopia, and it's a particular part of Ethiopia, in the very northern part of Ethiopia, very arid, and it's where three tectonic plates meet. It's called a Danakil Depression, and it's an area of very high, um, very high volcanic activity. So all the features that you see in this particular area called the Danakil Depression are essentially volcanic in origin. The talk is about Ethiopia, so I thought I'd just educate you a little bit in the geography and some particularly interesting geography at that in Ethiopia. So I remember this case very clearly. This is not the clinical photograph of my particular case, but you can all um, make a very good assessment of that and tell me that looks like a nasty injury, doesn't it? It's a compound tibial fracture, and I remember the case very clearly. That is the genuine original X-ray, and that was a case that I was rung in my first year as an on-call trauma surgeon. It was Christmas Eve 2007. I was on call and I took this call to say that this particular injury had come through the door and how can we now manage it. So, so I'm not going to give away the answer, but this is first name Kelly from Boston, and I say Boston, Lincolnshire, not Boston, Massachusetts, USA. This is a case study of Kelly, and a lot of what I am going to talk about is about how we have refined our thinking and our ability to manage this type of injury, this type of injury that Kelly unfortunately suffered on Christmas Eve 2007. And I'll show you her most recent up-to-date X-ray with how it turned out in the end. So our knowledge of wounds, and this is a talk of compound tibial fractures. So I'm going to just talk a little bit about the history of how we have refined our management. And a great stride was made in the 1800s. A chap called Joseph Lister, who was a professor of surgery in Glasgow, and he realized that there was something called bacteria which contaminated wounds. And if you got rid of bacteria, then essentially you could control infection and death. And in Joseph Lister's time, the never mind infection, but the mortality rate was almost 50% if you got if you had a compound tibial fracture. And that's because in the 1800s, then people were mainly working in agrarian or in dirty conditions, unsanitary conditions, so their wounds were very heavily contaminated. So never mind the amputation rate or the complication rate, the mortality rate itself was very, very high. And that was his challenge at the time. And Joseph Lister found that if you could irrigate a wound, reduce the bacterial load, if you could debride necrotic tissues appropriately, and he instituted the use of something called carbolic soaked dressings. Carbolic acid was a byproduct of oil production at the time. And he found that if you could soak these wounds in carbolic dressings, you could reduce the risk of mortality and the risk of sepsis as a result. So just introducing that very simple protocol, he made great strides in reducing the risk of in reducing death rates from a compound tibial fracture. And the case in question was a little boy of about 6 who'd fractured his tibia. When everyone was saying he should have an amputation, Joseph Lister stepped forward, treated this boy, and lo and behold, he survived. And that's a seminal case that's gone down in history as marking our great understanding of sepsis after compound tibial fractures. And Joseph Lister's infection rate was down from almost 100% to 15%, not to mention that the mortality rate he was able to reduce from 50% to almost like 5%. And then we take the history of this condition a century or so forward into the Second World War, and the challenge that Joseph Lister faced after rescuing the limb remained. So in the Second World War, we had compound tibial fractures, and the problem was not just saving life, not just saving the leg, but having to manage bone defect. And you can see an example of a big bone defect, such as this. And bone defects were inevitable when you did a thorough debridement, and continues to be a challenge now. So if you do a thorough debridement of a compound tibial fracture, managing the bone void is a huge challenge. If you wish to read a little bit more about how our knowledge progressed about open tibial fractures, then please feel free to read that paper which I've put in the slide. Another huge step in the salvage of compound tibial fractures was the progress with plastic surgery and skin cover techniques. And it was in the Second World War that people start to innovate about how do we cover tibial fractures, because we know that if we get the skin coverage, then the wound is less likely to be infected, the fracture is more likely to heal, and we're more likely to be able to salvage the leg and promote union. So that was a huge step in the Second World War. And then the third main thing that we appreciate from the Second World War was the introduction, widespread introduction of penicillin and antimicrobials. So those three things constituted a huge step forward in our understanding of how to salvage compound tibial fractures. In America, just after the war, there was a benchmark, a seminal paper produced by someone called Gustillo, and we ask about the Gustillo classification very commonly in trauma meetings, in MDTs, but also in the exam scenario. And you can see going from a grade 1 to a grade 3C, the wound is much more severe, isn't it? So, for instance, a grade 1 might be almost like a pinprick type injury, whereas a grade C, you can see that the bone is multi-fragmented. Many of those bone fragments will be non-viable, and that's the same for a 3B. In a 3C, the key difference is the lack of vascularity, so ischemia, which is associated with certain high energy tibial fractures, which are compound. So you can see how for a limb to be viable, number one, there needs to be blood flowing in it. Without blood flowing, that limb is not viable. That seems very, very common sense. Number two, you need coverage. So you need to be able to cover the bone defect. And number three, you need viable bone ends so that the fracture is able to unite. And in order of requirements, so number one, you could say, well, the leg needs to be perfused, no blood, no union. Number two, you need good skin coverage for union, and number three, you need viable bone ends for union. And you can live with a ununited you can live with some difficulty if you have an ununited tibial fracture. Uh, you can even live with a chronically infected tibial fracture in some cases, but it's much easier to survive if your fracture is at the very least united and in one piece, because then at least you have, pardon the pun, you have a leg to stand on. So in the very simple grades of tibial fractures, and you will see how this becomes relevant to the LIMIC, to the management of injuries in less advanced, less wealthy economies in the course of this talk. But in the very simple grades of tibial fracture injuries, then we can use kind of complex, we can use um, fairly straightforward, conventional and traditional means of fixation. So we can plate low-grade fractures, we can nail low-grade fractures, and we have good success rates with very simple surgical means. But the challenge remains when you have bone loss. And if you have bone loss, then we owe a vote of thanks to this particular surgeon. This surgeon goes by the name of Gavril Ibramovich Ilizarov, and he was a surgeon in Russia in the 1950s. So he was developing his theories about compound tibial fractures in isolation from Gustillo. Gustillo was an American, and Ilizarov was a Russian, and they didn't have any interaction, no cross-fertilization of ideas. But Gavril Ilizarov came into the consciousness of the medical community in Russia because he was able to describe and reproduce a very clever, neat way of filling bone defects. And like I said in my previous slides, filling a bone defect to permit union is a huge challenge in the context of high grade tibial trauma. And the case in point that Gavril Ilizarov became famous for was when he salvaged the tibial fracture, the compound tibial fracture of a famous Russian athlete. So this is Valery, if I'm not mistaken, Brezhnov. He was a high jumper who suffered a tibial fracture after he won the gold medal in the 1972 Olympic Games in Munich. And this high jumper was counseled to have an amputation until someone told him about this weird surgeon in the far reaches of Siberia who was using a very crazy technique to salvage infected non-unions. So this chap took himself off to to meet Dr. Ilizarov, Professor Ilizarov, and Professor Ilizarov treated him successfully. And this case study became very, very well known in Russia, and then after, and then by extension became very famous throughout most of Europe, and it became a seminal case whereby most Western surgeons then adopted this technique or that Ilizarov described. And the rest of this talk, this section of this talk, is dedicated to Ilizarov's work and how he's transformed the management of compound tibial fractures. Ilizarov was published a few papers on this technique, and his paper ranks in the top 30 papers of most cited orthopedic publications. And if you look at Gustillo, he ranks at number 12 in the list of most cited orthopedic publications. And I mean orthopedic publications ever. And Ilizarov ranks at 29. And that was his paper talking about the genesis of tissue and how you can create tissue in the absence of tissue, specifically how you can create bone in the absence of bone. And what Ilizarov realized was that if you undertake a very low energy corticotomy, so what we call a fracture of the tibia, you can then stretch it. And if you stretch it at a very low rate, 1 millimeter per day, you can actually reproduce bone. So a fracture initially forms callus, and if you stretch the callus at 1 millimeter per day, eventually that callus will undergo the process of osteogenesis, and instead of callus, you will have a stretched out piece of bone. And that was a truly remarkable discovery that Ilizarov was able to make, and he reproduced this in laboratories. He reproduced this in clinical studies, and here's a histology of one of his cases. So the very black, thick lines represent cortical bone, and you can see there's two cortices at the top and two cortices below, and you can see in between them, you can see an area of cartilage that is formed. And this is cartilage that is essentially the precursor of bone, cartilage that is formed from the distraction of callus. And if you leave that for long enough in the correct circumstances, you can see how that cartilage has now transformed into what we call lamellar bone. So you can see the thick black cortices at the top. You can see the thick black cortices below, and in between you can see histological bone, lamellar bone. And that was Ilizarov's discovery. And even with very neat, very elegant vascular studies, he was able to show that actually this bone behaves like true bone with its own blood supply. It's viable, and that was a truly remarkable discovery. So here's an animation of how this works in practice. So I've told you a little bit about the history. I've told you a little bit about the history of how it was discovered. But you might be asking, well, how does it in practice? How do we actually make bone? How do we create bone in an area of gap? So here's a simulation of a comminuted fracture, and let's assume it's a compound fracture. So the first step of this particular treatment of Ilizarov's distraction technique is to remove what is damaged bone, and you can see that creates a very large defect. And then above it you have the corticotomy. And then Ilizarov designed this very specific type of external fixator called a ring fixator, or the Ilizarov apparatus. And this fixator is essentially bolted to the tibia with a sequence of half pins and fine wires. And this was sorry, I've got a little bit of echo. Is someone able to put themselves on mute?
Tickets, brown cards, and passes. Thank you.
Thank you. Okay, so you can see how the fixator is bolted with very fine wires or with half pins. And if I just progress the animation a little bit more, you can see the completed external fixation on the tibia. And progress a little bit more. That's how the corticotomy at the top looks like. And then we move essentially move the ring down a millimeter a day, and you can see the cortex meets at the bottom. You've left callus, that gray segment, which then changes into bone. And that's a really neat way that you can fill in a bone defect. And this is what we call bone transport. So in the course of my talk, if I use the word bone transport, you'll know what I mean. So here's an example that I had maybe a few years ago, a builder in Leicester who fell off some ladders, and you can see he's got a tibial fracture. This was actually compound, and you can see a part of the tibia has rotated almost 90 degrees and is sitting sideways. And what I can tell you immediately is that rotated segment will be avascular. It will have lost its blood supply. So it's not as simple as essentially putting it into place and fitting and bolting it into place. If it's lost its blood supply, it will not regain its blood supply. It needs to be disposed of. And if you don't dispose of, at the very least, you will have what's called a aseptic non-union. At the very worst, you will get infection because of dead bone, and you'll get an infected non-union, which is a little bit more complicated. So we can repeat those steps that Ilizarov described in his bone transport. We can put on a fixator. You can see I've done a corticotomy at the top, and I'm stretching it 1 millimeter a day. And at the bottom, you can see I've got contact between the cortex, which has moved, shuffled its way down to the ankle. And you can see I've got contact. And when I take my fixate, when I take part of my fixator off, then you can see I've still got my lengthening segment at the top, the new callus, the new bone that's formed, and distally I've now got union. So the gap which is there because of the rotated segment has now united, and I'm just waiting for my proximal regenerate to fully heal, and that's what it looks like when I take my fixator off. I might put this person in a cast for a month or so, but essentially now he has a united tibia with no infection. And as I said, in Lister's day, that would have been considered a miracle. 2016, anyone know what happened in 2016 in Leicester that was historical? Shout out or type in the chat if you think you know the answer. Anyone? While I have a sip of water. 2016, what happened? Jeff, you ought to know this. In 2016, a biblical event happened in Leicester. You've all heard about how David beat Goliath. Yeah? In 2016, Leicester City Football Club defeated the might of the entire Premiership. It beat Liverpool, it beat Arsenal, it beat everyone to win the championship, and it'll probably never be repeated. And this patient of mine was celebrating Leicester's win, and he celebrated by going to France. And he was a diehard Leicester City supporter. He went to France the following year because Leicester City won the Champions League for the only time in their history they were in the Champions League. He fractured his tibia in France, and he had what was at the time was considered a very standard technique fixation in France. And unfortunately, he developed infection. He developed infection as a result of the fracture, and you can see that tibia looks like it hasn't fully united, and you'd be right. But in addition, I can tell you that fracture is now behaving like an infected open tibial fracture. It's closed, but it's behaving like an open tibial fracture might behave further down the line. So he needs complex treatment. He needs that infected bone excising, and this is an extension of the technique. So I described the technique initially in my talk as one that is used for compound tibial fractures, but we can also use the same technique for infection when we need to get rid of infected, dead, necrotic bone. So that's what we do with him. We remove the infected metalwork, we remove the dead section, and we create in the same way a ring fixator, slightly different design to the one I've showed previously. You can see the corticotomy at the top. And eventually we shuffle the tibia down, and we get a union. I know it looks a bit wonky, but most importantly, it is in one piece. That tibia has united. He's got a leg to stand on, and he's got no infection, and that is amazing. And here's another example. So this chap came off his motorbike in the 1970s. He came to me in his late 60s, Almost 40 years later, he came to me because he'd been treated for a compound tibial fracture in the 1970s, and it had resulted in chronic infection. So we've removed the infection, just like we said we did in the last case. We've removed infection, and with bone infection, you unfortunately have to remove infection like it's a cancer. You have to get clear margins up and down, and um, you have to clear the infection. And then we have a corticotomy and bone transport. Yeah. And in this case, we've got a double transport and we've filled in the defect. And in this case, we've done it in reverse from distal to proximal. And that's the end result. Free of infection and a united tibia. Just a little bit of a digression. So, one thing that human beings do is that we learn from previous experience. We learn facts, and then we develop our understanding of facts. We then start to apply facts. And then as you become more and more experienced with knowledge and understanding, then you start analyzing it. You start playing around with the facts in your head. You start experimenting. You start creating new concepts. And the reason, and I will show. Sorry, the reason why I'm showing this slide will become evident in a minute. There's a similar Japanese um, saying about following the rules initially, and then when you become good at the rules, then you break the rules, and then finally, when you become an expert, you start to make new rules. So we've done something similar with bone transport. We start to break the rules. We start to create more rules. We start to change the rules that Ilizarov initially described. And in this case, you can see we've done something unusual with a case of chronic osteomyelitis. We've cut out the infection, and we are now transporting it not from the outside with external fixation, but from the inside with a neat little cable pulley system. And how can we modify the technique further? So external fixation, as you can imagine, is bulky. It's on the outside. It's inconvenient. Could we potentially put internal fixation and do Ilizarov's bone transport and lengthening with internal fixation? And the answer is now we can, because we have neat internal implants which can expand. And this is one particularly designed with two with a motor inside the intramedullary nail with a remote control, which allows expansion, lengthening of the nail, and therefore bone transport, or in this case, we can lengthen the nail. But the principle is the same. This is distraction histiogenesis. This is distraction osteogenesis, and it's the same principle that Ilizarov described, just with different application and with different hardware. So how does it all fit into my work abroad? And I became interested in this topic of tibial salvage, tibial reconstruction, because of my visits to Ethiopia. And I'm very humble enough to accept that I probably wouldn't be anywhere near as good as at this particular technique if I hadn't been to Ethiopia. So I'm very grateful to the people of Ethiopia and to my colleagues and partners there who made this possible and who've enriched my own learning. So I was enticed to visit Ethiopia in 2015 for the first time. In the picture on the left, standing behind me is my former registrar called Lawrence Wicks, and it was his idea to visit northern Ethiopia because he realized there was a link between Leicester and this particular city in Ethiopia called Gondar in northern Ethiopia. So we went out as a group of clinicians interested to learn, to see, and maybe make a longer term partnership about developing services there. And my first impression was that Ethiopia was a rich ground for treating compound tibial fractures. And most of the tibial fractures which I saw in Ethiopia were very similar to that one on the bottom left. Open wounds, they didn't know how to close them. They had very basic equipment, nothing like even the most basic equipment that Ilizarov had designed. And so this led to a sequence of visits, and this is key if you want to develop partnerships, if you want to help develop infrastructure in limited settings. You have to have you have to have resilience to visit, visit, and visit again. Commitment is key. Hoping that you will maybe do one or two visits and change something, that's really unlikely. It takes it takes years of commitment to really see change and to really help people develop um, in regions where resources are limited. And this was essentially the type of injury I'd see. I'd see compound tibial fractures, mainly as a result of easy access to ballistic weapons. So AK-47s are very, very common in northern Ethiopia, and unfortunately, petty arguments, disputes are settled with an AK-47. So I saw these injuries galore, and it made me think about my own practice. It made me understand the topic, but more importantly, it made me think, how can I help and develop services locally in northern Ethiopia? So it wasn't just compound tibial fractures, it was other trauma too. And I was very fortunate that I found partners who were interested to help me. So northern Ethiopia, there it is, and that red mark there is Gondar. It's close to the border with Sudan, close to the border with Eritrea. It's about the seventh or eighth largest city in Ethiopia, and it serves a catchment population of almost 6-7 million. And partnering with Rotary International, particularly, I was able to raise funds. I was able to raise funds sufficient to equip a operating theatre. So I asked the University of Gondar to create the theatre, to build the theatre, and I said, in return, if you build it, we will help you um, we will help you with equipping it correctly. And we went from something that was really, really basic. So, I mean, to you, that just looks like a room with a marble floor, lots of people standing around, there's a light and very little else. And if you compare it to what it looked like after we'd been involved, I'm sure you'd agree that that's a huge difference. And it wasn't just building, it wasn't just buying stuff, but um, it was also contributing to their knowledge. So we partnered to run workshops. Every time we go, we would enrich their knowledge with interaction, case discussions, joining with a trauma MDT and reviewing X-rays. And this was the type of case that we would find commonly, especially after the civil war in Ethiopia in 2018, 2019. So ballistic injuries, missing bone, missing skin, and we taught them how to put on a basic Ilizara fixator, and we showed them this technique. There's a gap, and you can close it with a corticotomy and shuffle the bone along. Bone transport, like I mentioned before. Here's another example where there's actually bone missing. So the skin's healed, but there's bone missing. And you can see bones missing. So this isn't a leg to stand on. There's very little support in it, which is why he walked permanently with a stick. And you can see again, that's a huge gap that we have to bridge. We do a corticotomy just above the ankle. You can see that is the corticotomy. And in reverse, we are shuffling that bone segment from the ankle up towards the knee to fill in, bridge that gap. So this brings me back to the case I started with, Kelly from Boston. How did it happen? She was hit by a car, Christmas 2007, and that started my own personal journey in managing compound tibial fractures. And that was Kelly's original X-ray, multifragmentary, as you can see. Unfortunately, you can't see the defect, but what you can see is nice callus that's formed, which will now solidify into new bone. And in Kelly's case, we were able to remove the fixator and swap her to an intramedullary nail, which meant that her rehabilitation was just that bit quicker. So I'm very pleased that at least one of you put external fixator at the start of my quiz. What would you consider to be the most important development in orthopedics ever? And I'm not going to pretend that it's only the fixator, but there are many crucial developments in orthopedics. And obviously, the one that I'm most passionate about is the one that I've talked about, which is the management of compound tibial fractures, tibial infection, complication of fractures, namely infected non-unions, gap non-unions. And very fortunately, I'm not the only one who thinks that way. In the 10 inventions that shaped modern orthopedics, both the intramedullary nail and the ring fixator come out somewhere in that top 10. Just a final few thoughts and comments about my work in northern Ethiopia. I mean, you've seen that picture before. And that was the first group that we went out in 2015. And orthopedics at that time in 2015 was didn't even exist in northern Ethiopia. So trauma was managed by general surgery, and that was the base from where we started. And as I showed you the pictures of the very basic theatre space that we were able to use, which we were able to then transform, that was the second part of our journey. And then the third part of our journey has been to upskill these committed professionals so that they can provide the service that their community deserves. So number one was infrastructure, and as I said, transforming that with the help of partners like Rotary International made a huge difference. So now in northern Ethiopia, if you suffer any kind of trauma, generally speaking, you're in good hands. At least the equipment, the basic services are available, whereas previously you would have got very basic treatment, and if you had the resources, you might have to travel 800 miles to the capital to get yourself a fully trained orthopedic surgeon. So that was number one, developing the infrastructure. Number two, it was creating the partnerships that make a difference. And as I said, you can't make partnerships just by one or two visits. Partnerships are made because people trust you. And you can only get trust by spending time with other people, by um, showing your genuine interest, by repeated visits, maintaining contact. And that's how we got a department out of general surgery. We then grew a a dedicated trauma department. And we were able to find the funds, find the partners to support subspecialization. So as many of you will know, within trauma orthopedics, there are people who specialize in spine trauma, in pelvic and acetabular trauma, in lower limb trauma, in upper limb trauma, perhaps even hand trauma. And so we were able to grow that department because of the partnership over 10 or so years. And when you show that commitment, then you get other benefits. So once we made that commitment, once we grew that department, then other interested parties like the Jaipur Limb Project. And the Jaipur Limb Project, I'll invite you to have a look at it online. Perhaps some of you will know about it already. But the Jaipur Limb Project is a way of funding artificial limbs, prosthesis for people who can't afford it. And amputation, irrespective of the best trauma surgery, unfortunately, amputation is a common outcome for many trauma patients in limited income countries. And believe it or not, being able to buy a prosthesis is prohibitive for many people who are living on the poverty line. So our partnership with the Jaipur Limb Project meant that for the first time, patients were able to afford a prosthesis, not just afford, sorry, were able to avail themselves of free prosthesis made locally in northern Ethiopia. Prior to this, there was one limb fitting center, and that was 800 miles away in the capital. And now people can get limb fitting done locally, and it has reduced the stigma hugely. So we see people walking in with, with crutches or with other supports or in a wheelchair, and then we see them walking out again. Some of them are even bilateral double amputees. And then further to that, we are preparing the next level of treatment. So that involves ongoing partnership, ongoing um, support, uh, networking, trying to get people trained in the subspecialties that matter. So you can see a theatre which they would never have dreamed of having, which is now running on the top right. On the bottom left, what you're seeing is a child who had a congenital hip dislocation. So we've grown children's orthopedic services. The second picture from the left is a pelvic sacral screw. So we've developed pelvic and acetabular fixation. Of course, the compound tibial fracture techniques that I've told you are well embedded and are in place. So the current project is to develop hand surgery, and hand surgery in much of Africa is completely neglected. There are very few dedicated board certified hand surgeons, and that is currently what our target is. And so we've partnered with a hospital in South India who have very kindly subsidized a fellowship for one of our surgeons, and he'll be going out this September for a 12-month program to become the first fully trained hand surgeon in northern Ethiopia. There is no hand surgery outside the capital, Addis. And that takes some doing. Obviously, funds, we have to raise funds, best part of $12,000 for travel, accommodation, and so on. So I will just end on that note that assist, the partnerships that you develop, the partnerships that you make are absolutely crucial for assisting development of surgery in low-income countries. And it's a partnership that has to take patience. It takes time to form relationships over many years so that people trust you, that people realize what your motives are, and that you can in turn really understand what their needs are and make your solutions fit for local purpose. Thank you very much for listening to me, and I'm really grateful to folk um, who've invited me to this talk. Thank you very much.
Thank you very much, Mr. Abraham. That was very, very insightful, very inspiring. Uh, Most of us here want to join you on this journey. Hopefully, we can join you at some point to Ethiopia to help on this inspiring initiative. We've got a few questions that came in on our registration forms, and they've come in on the chat as well. If I can read them out to you. So the first question was, what were the most difficult challenges you faced while working in Ethiopia? I'm sure you might have touched on this in your talk.
Um, so I'm going to be I'll speak like a human rather than a surgeon, if I may. And I would say that getting trust of people is the most crucial thing, most difficult thing you can do. And that's like any relationship, isn't it? Any relationship with um, professionals, be that at your place of work, be that friends, be that family, getting trust is the most difficult thing. And trust, and I can't give you a formula as how you get trust from partners, but it comes from showing understanding, from being a good listener. It comes from trying to meet them in their situation. It comes with giving them respect. It comes with showing commitment by repeated visits, staying in contact, showing your face time and time again. And I know for sure that that is why I have been able to develop the serv develop this help develop the service like I've described. So I'd say the most important, most difficult thing is getting trust, and that's completely different to perhaps what you might have thought, Jeff.
It's a very insightful answer, Mr. Abraham. I think George has a question here.
Was an amazing talk, and thank you. I'm really fascinated with all the work you've done, and I wanted to ask, how easy was it for you to involve industry into
easy was it to involve industry? Um, the answer is yeah, both easy and difficult. So I'll admit I'm a little bit shy about asking for money. Some people find that an easier thing to do. I'm more the guy who like turns up, gets my hands dirty, and does the teaching, does the clinical work. But you do need people who are brave enough, bold enough to ask for help. Um, so the most of the help that we have got is by donated materials. So we've been able to get some donated materials, and the challenge with some countries is the importation of donated materials. So some countries, have multiple layers of bureaucracy, of paperwork, and getting equipment in is a real challenge. And I'd say Ethiopia is about the worst country trying to get equipment in because there's a lot of suspicion, there's a lot of paperwork, there's a lot of history that this might be used for the wrong reasons. So I'd say in my particular venture, then I'd say getting industry support has been quite mixed. Many people have been very willing to get me equipment, but then again, actually physically getting it into Ethiopia has been very challenging. On the other hand, many people in industry are really very keen to go out and visit, and believe it or not, most medical implant companies will allow their staff to go out for at least a week every year as part of a charitable or a kind of a giving back policy. So I have benefited from clinical staff from Synthes, for instance, implant company, who've come out and helped train local people in sterility, in implant storage, that kind of thing. So yeah, the answer to your question, I'd say, is that it's been mixed.
Okay, thank you very much.
Um, Another question is, how does one get involved in global surgical work? What's the path to doing this? Um, I think Nizar has asked a similar question as well. Uh, he's wondering if there's any formal body we can join that arranges orthopedic visits to different places.
Yeah, so for orthopedics specifically, then there are many charities that are available. So I'm part of a body called the World Orthopaedic Concern UK. So you can Google that, World Orthopaedic Concern UK, and you can check out the website, and they'll tell you about the projects that we're involved with, the people who are involved with. But I can tell you that irrespective of formal organizations, there are many people who individually, off their own back, are undertaking charitable work or development work, as I like to call it, uh, in their own free time, with their own resources, often with their own money. So if you ask around, you will generally be able to find someone, and it's quite easy to ask people, to point you in the direction of someone who's looking for volunteers. Uh, yeah, I think that's pretty much it. I would say, there are many of the subspecialist societies. So, for instance, the British Society for Surgery of the Hand, BSCOS. Many of them have a group or a subgroup, should I say, who who are leading on development work. And some societies, some seem to be better developed further down the road, and some societies are perhaps just paying lip service. So yes, I mean, unfortunately, some of it is trial and error. I think if you want to get involved with overseas development work, then I'd say resilience and stamina is probably the key attribute you can have, because almost certainly you will perhaps go on a visit, you will not feel if it's quite right, and then you will need to go again. And your third visit, you might be really demoralized, and you might never want to go again. So I think the key thing I'd say is resilience and stamina if you want to have a really meaningful effect or really meaningful partnership with a project like this.
Sure, Abraham. Um, I've got a second year MBBS student asking, what do you suggest an MBBS student in second year can do to ensure a smoother path into this field?
Again, if you ask around, it's a similar question to the one I gave earlier. If you ask around, you will find people who are involved. And if you find people who are involved, then often you can find that many organizations have funding specifically for medical students, for instance. And if it might be possible because if as a medical student you're a bit broke, you can't really fund your travel. But many organizations might have funding for travel abroad. But generally speaking, I would say it's nice that you want to be involved at that early stage, but expect your input to be quite limited. You can always volunteer and be part of a team that's helping, for instance, setting up a conference or a workshop. But how much you can really put in becomes more meaningful the higher up the ladder you go as a surgeon.
For that. Mohammed Onsa is asking, I'm fascinated by this partnership and project. Being from a low-income country myself, I know that it's more feasible to develop a doctor compared to the rest of the clinical staff. How was the experience of developing the rest of the staff apart from surgeons, for example, nurses and nurse practitioners, physiotherapy and theatre staff?
So my experience is that physiotherapy is quite well developed. So physiotherapists as an alternative provider for MSK treatment is quite prevalent, and also because physiotherapists can set up as private practitioners, then there is a market with plenty of physiotherapy. I'd say nursing expertise, I agree, is very hard to develop, and I think because perhaps the remuneration as a nurse is globally not what it ought to be, then the quality of nursing can vary tremendously. So that's been difficult, but we've t for my personal experience, I can tell you that on at least three of my visits, I've taken physiotherapists with me who have formed partnerships with physiotherapists in northern Ethiopia and continue to maintain those links. And for instance, the artificial limb project, the Jaipur limb project that I mentioned, that is run entirely by physiotherapists. There is no medical doctor leading that service. So that's a tremendous service that we've been able to support limb fitting by physiotherapists. So it is possible. You have to find the right people, make the right partnerships, and again, like I said before, um, it's all about forming partnerships with trust on both sides.
Sure, Abraham. So it's all about building that trust, spending the time, and spending your valuable energy to build that relationship. Um, I've got another question from somebody who's interested in general surgery, who they're wondering if there are any similar initiatives for supporting doctors in remote countries that one could get involved with.
Oh, absolutely. There is, and I know for sure that there is a general surgery project from based in Northampton General Hospital. One of the surgeons there who has a link with a project, I think in West Africa. So, absolutely, in the same way that you can find orthopedic projects dotted around the UK, partnering with different parts of the global South. You will find similar partnerships with general surgery and the global South, no question. You would have to Google it,
Yeah.
and I'm sure you'd find it. Thank you.
Sorry to be. Yes, there are general surgery initiatives. There is one with surgeons from Leeds and Birmingham, Mr. Adam Peckham Cooper, Mr. Matt Lee. They recently traveled to Ghana and they teach hernia repair. So yes, there are initiatives from UK, and Mr. Adam Peckham Cooper is one of our next speakers, and he's going to talk about his experience about teaching hernia repair in low and middle income countries in Africa. So
That's
for all
great.
the
Yeah.
audience, stay tuned.
Yeah, yeah. And so, I mean, just on that topic, there are three procedures that the WHO considers to be the basic surgical procedure that everyone in the world should have access to. So everyone should have access to a safe cesarean section. Everyone should have access to a safe laparotomy, and everyone should have access to to safe treatment for a compound, a fracture of some kind. So those are the three what are called the three bellwether conditions that are used as a benchmark to rank or rate healthcare systems and surgical access. So, absolutely, is there a role for general surgery involvement? The answer is yes.
Perfect, Mr. Abraham. I think last couple of questions. One from Surya. That's a very inspiring lecture, Mr. Abraham. I'd like to ask a generalized question. How are you able to manage your time and schedule and plan around work or something like this, especially when you're a very busy person?
Surya, as you get more senior, you become less busy. Don't let consultants tell you otherwise. Yeah. There, you can make a choice. You can, you can go play golf or you can go to Ethiopia. It's just a choice you make. Yeah. There is time as you get older, no question. I think the busiest time is when you have young children, when you have a young family, you're trying to juggle, on calls and so on. I think if you keep going and if you have, I think it's really important to have support from your immediate family. So even when my children were, I guess they were coming up to teenage years, my wife was very supportive of me going. She knew that it was something I would want to do. So as long as you have the interest, I would say it's not difficult to find the time. And let's face it, if you're doing something you really enjoy, it's not really hard work, is it?
Fantastic answer, Mr. Abraham. Ultimately boils down to your priorities and what you value in your professional life, as I understand it. Nizar's got a follow-up question. Did the partnership that was established, was it with government or university hospitals? How did you tackle issues such as corruption?
Well, you could tackle some issues. So, for instance, I remember a nailing set. It uh, I remember a nailing set that disappeared from the hospital and it had been taken to a private clinic, and that nailing set was obviously a donated set. Nailing should have been done free for patients who couldn't afford it. It was being uh, uh, used in the private a hospital for a huge amount of money. And the only way I could tackle it is by by challenging the person and having a conversation in honesty but with kindness and saying that set needs to come back. And it did come back. So I think some t corruption you can tackle just by speaking up. And let's face it, as an outsider, I can speak up because no one's going to damage my career. No one's going to restrict me in any way because I can speak up. Whereas local people might find it much more harder to speak up. So in that sense, you become a voice for the well-meaning professionals who you support. So I think that's quite important to be able to stick up for your colleagues. It was government hospitals that we partnered with. It was a university hospitals, and that's why we were able to grow the workforce. It was a University Hospitals of Gondar is a medical school. In fact, the oldest medical school in Ethiopia, believe it or not. It dates back to the 1980s, and it it was the reason why we were able to grow the service in a slow, steady, limited way, and the service is nowhere near as grown as it ought to be. There's a huge restriction and depletion of resource, as you can imagine, in a country which has experienced civil war. So it has been tough, but the benefit of a university hospital in a place like Ethiopia is that you're not short of people. You've got plenty of workforce who all are interested, willing, and keen to learn, and that's been the main bonus.
Thank you, Mr. Abraham. Last question from Emmanuel. Um, Given the growing demand for MSK care in northern Ethiopia, are there any plans to expand this partnership into something like an independent orthopedic center in Gondar, a potential hub for orthopedic excellence and training? What are the next
Absolutely.
steps, essentially?
Yeah, so wouldn't it be nice to have so that part of northern Ethiopia? I mean, Ethiopia has I don't know. Emmanuel could tell me it has about 10 or 12 states, 10 or 12 regions, and Gondar is in a region called the Amhara province. And wouldn't it be nice to have the Amhara Institute of Orthopedics (AIO) at once point in the future? But I think rather than going for like big glamorous titles, I think we do the simple things first, which is that we train people to do the basics: hand surgery, spine surgery, pelvic surgery, pediatric surgery. I think we have to do that because I think if we do that, then the system will grow organically. It will grow by itself.
Mr. Abraham, just one last question before we wrap up. Um, Thank you for your lecture. Did you have to send a team to organize your first series of surgeries? And were there any requirements you have to satisfy in the UK to perform surgeries abroad as a UK doctor?
So you don't have to. You ought not to be practicing abroad if you haven't got a GMC registration. So you have to keep your registration, your appraisal, all up to date. And if you want to work abroad, then you have to declare it to your trust to say this is part of my scope of work. Apart from that, then there is nothing you need to declare. There's not really any meaningful insurance or anything you can take out. You have to just say, okay, well, if something happens, then we deal with it at the time. We'll be in the hands of local doctors who will hopefully ensure we get the best possible treatment or put us on the first flight home. So that is really what you need to do at home. Many hospitals will actually give you professional time off, and I was able to negotiate 1 week per year with the University Hospitals of Leicester. So they give that to me in addition to my annual leave. In terms of teams going ahead, the answer is no. I don't believe in like helicopter surgeons going in, flying in, doing lots of surgeries and leaving. I believe that the best model is to go form partnerships, understand things firsthand, teach them how to do things, develop skills slowly, and that's how you create a sustainable workforce. I think that's the better model than having a team that goes in, triages everything, then you fly out, do the surgery, and then fly out again. I don't think that's a particularly good model.
Thank you so much, Mr. Abraham, for your exciting and inspiring session. It was indeed very useful for all of our listeners. So we'll wrap up our session there on a quick note. The WHO currently says that there are about 5 billion people who lack safe and affordable surgical care around the world, and 30% of the global burden disease is from surgical conditions. 6 million people around the world die from orthopedic related conditions, and 50% of these are preventable. So, through initiatives such as what Mr. Abraham has done, and through initiatives such as InciSioN UK, we aim to spread awareness and we aim to keep inspiring people in global surgery. Thank you, Mr. Abraham, and thank you everybody for dialing in today. Please complete the feedback form to let us know how you felt about today's session and if you require a certificate. And please follow us on social media on Facebook, Twitter, and Instagram. We have a series of sessions coming ahead in general surgery, plastic surgery, vascular surgery, and urology, all focusing on global surgery around the world. So stay tuned for further episodes. Thank you.
Thank you very much
Thank you,
for
Mr.
having me.
Abraham.
Thank you. Have a nice
Thank you.
weekend, everyone. Thank you.
You too. Thanks.
Thank you.